सर गुड आफ्टरनून।
हाँ, गुड आफ्टरनून, गुड आफ्टरनून। हम जस्ट अपने लैपटॉप से ट्राई करते हैं जुड़ने का, ठीक ना?
जी जी अविनाश, गुड इवनिंग।
जी, प्रणाम सर।
गुड आफ्टरनून, गुड आफ्टरनून।
गुड
तिवारी सर
आफ्टरनून।
प्रणाम।
हेलो तिवारी सर, प्रणाम सर। जुड़े हुए हैं? हम जस्ट लैपटॉप से बॉस जुड़ रहे हैं, ठीक ना?
राइट 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 राइट।
Yeah, good afternoon, Dr. Tiwari, sir.
Good afternoon, sir.
Yeah, good afternoon, Dr. Amit. Luckily,
very good afternoon, sir.
I
Very
could
good
join
afternoon.
at time, I think, well in
Yes,
time.
yes, sir. You're well in
गुड
time, sir.
आफ्टरनून सुधीर सर। गुड आफ्टरनून
Perfect.
सर।
Yeah,
Perfect.
Dr. Avinash, good afternoon.
गुड आफ्टरनून सर। गुड आफ्टरनून।
So actually, I was just busy with a critical patient ICU. I thought I would be stuck up there, but luckily, the patient has settled down now. So,
This is the unpredictability of the medical profession, no?
yes, yes, yes.
We all have this problems coming up now and then.
Right, right, right. It's because no, our is the only profession. Every profession serves mankind, but we are the only profession who's saved mankind. Am I right?
Right, right. Absolutely
That's why you
right.
are called God. That's why
Yes.
you are called God.
Yes.
Though
So,
it looks like joke, but it is the truth.
yes, sir.
Sir, it's 2:30.
Yes.
So the meeting should start, no?
Yeah, you
Yeah, but
introduce Dr.
I'm waiting for Avinash.
Avinash is yet to join. Yeah, he's joining from his laptop.
Yeah, yeah. How are things, Mehta Saab?
एकदम first class चल रहा है. Good.
ठीक है.
And your vision of these lectures in different specialties, I think it has become very, very popular now.
Yes, sir. That's right. That's right.
Actually, I yesterday also night I got a request from some resident in Gujarat. I forwarded Dr. Amit's number. Though he also wanted to join. मैंने कहा yes. Initially we had capped a cap of 100 students only. I think we should open to all. I think.
Yeah, that is good. Actually, this was the beginning, so I was also not sure what to do, what not to do. And this was the
But
first.
now, actually, sir, we are not actually right now. At this moment, we are. I think all the ICP programs and
Yeah.
these lectures, they're all flying very high. Probably we are flying in the spacecraft now.
No, that is the vision of a teacher. Dr. Tiwari has been a professor of medicine for more than 35
Yes,
years.
yes, I know him very
And-
well. I have
And,
since many
and
decades.
that's why he could conceive what is the demand for the students. And this ICP short certificate course has been taken by the entire country in a very positive way.
Yes, yes.
So we are also getting frequent requests. The only issues which Dr. Tiwari sir discussed with me is the platform had a limitation of 100 people. So we are trying to increase more number of people to get registered and participate in this. It's going to be helpful for not only the postgraduates but also the people who are in their mid and above professional life, because most of them are so busy in their practical lives
Right.
that they forget the basics many times. So it's a good way of
I have joined
refreshing
on
themselves.
laptop, so we can start.
Okay. Okay, Avinash has joined. So can we start the proceedings, sir?
Yes.
Sir, to begin with, welcome all the delegates for this ICP short certificate course, hematology, and the moderator and the conceptualization of hematology section is Dr. Professor Sudhir Mehta. May I request Dr. Sudhir Mehta, sir, to say a few words for this hematology classes?
Yes, thank you, Dr. Amit. These classes in different specialties of medicine actually is the brainchild of Professor Tiwari Saab. And I'm lucky that along with Dr. Amit and Dr. Deria, we have been able to start this classes in benign hematology. Benign hematology is one area which is under-recognized in our country because there is no actual course the course are there, DM in clinical hematology or hemato-oncology. So benign hematology itself is a separate branch, and I think which fascinates all students in the field of medicine as well as the physicians. And we have started with the topics which are so relevant to the physicians who are working in the semi-urban and rural areas. And of course, to these topics are also useful to the postgraduate students. And now we have a good number of speakers in this series. And today we have Dr. AVINASH SINGH, an eminent metallurgist at Patna, and he's be delivering a lecture on approach to bleeding disorder. Over to Dr. AVINASH.
Sir, before we start with Dr. Avinash, I should be pardoned. May I request Dr. Tiwari sir to bless this meeting with his kind words?
Amit, I'm very happy to see this type of program going on very successful. I'm really, really very glad. And what I should say, I must say, or I must tell our teachers who are doing this job, I'm very, very thankful to them. I'm not obliging them, I'm thankful to them because their idea is spreading in the whole country. That is a thing, and that was actually my idea. You are with me from the beginning, you know, and we have seen the problems of the boys and students during our life. So let us go, and I think Avinash will do the justice. I know Avinash, and I have discussed many times for these things with Avinash. Avinash, go
Yes,
ahead.
sir. Yes, sir.
Welcome,
So,
Avinash. Dr.
yes,
Avinash, your topic today is approach to bleeding disorders, and we are not going to be a hindrance any further between you and your students. Kindly go ahead with your proceedings.
yes. So, good afternoon, everyone. Thank you, Professor Tiwari sir, Professor Sudhir Mehta sir, Dr. A.K. Das sir, and all the organizing committee members of this group for organizing this sort of webinar and giving us opportunity to discuss with PG students regarding these common, very important topics of our practice. So, can I share my slides? Sharing rights कहाँ से मिलेगा?
Yes,
आनंद जी?
Anand ji.
सर शेयर ऑप्शन है सर, वहां पे एक ग्रीन कलर का बटन होगा, आपके स्क्रीन पे दिख रहा होगा।
Participant chat reaction AI companion more stop video. तो इसमें कुछ फैकल्टी के लिए अलग क्या?
नहीं सर, रिएक्शन के बगल में सर ग्रीन एरो होगा एक।
रिएक्शन के बगल में ग्रीन है, AI कंपेनियन करके है, येलो है।
नहीं सर, एक शेयर लिखा हुआ होगा उसमें सर।
शेयर है नहीं, तो ये क्या, ये मतलब स्टूडेंट्स के लिए लिंक था क्या? या आप मेल कर देंगे हमको क्या? लिंक कोई अलग से लिंक है क्या, या एक ही लिंक है?
एक ही लिंक है सर, सब एक ही लिंक है।
तो फिर इसमें शेयर तो नहीं दिख रहा है।
सर मैं शेयर कर दूं यहाँ से आपका पीपीटी?
कर दीजिए, कर दीजिए, कर दीजिए, कर दीजिए।
Please send your slides to Dr. Anand, Mr. Anand. He will share the slides.
ऑलरेडी भेजा हुआ है ऑलरेडी। हम यदि खुद से
Right.
करते तो ज्यादा अच्छा था, लेकिन कोई दिक्कत नहीं, आप कर दीजिए। इसको स्लाइड शो मोड में कर दीजिए। हाँ ठीक है, थैंक यू आनंद जी। So again, good afternoon, and today we are going to discuss how to approach a bleeding patient, and it's very important. So why it's important? Because there are many problems in medicine that we see every day in our OPD, IPD, ICUs, and very few of the medical problem, they need thorough listening, thorough history taking to come to a diagnosis. We all know that history taking, physical examination is very important. Since our MBBS days, we have learned that we should take history, how to take history, What are the different components of history? Examination, these are important, so we all learned. But a bleeding patient's history is the most important. So a good history will tell you that what is the cause of bleeding in a particular patient. So what I'm going to present is just practical approach to a bleeding patient. No hi-fi, nothing, no more theoretical details. So whatever I'm going to discuss will be relevant in your practice, clinical practice, in your OPD practice. And I would discuss grosser findings, not the minute details which are important, which are difficult to remember. So evaluating a patient with a suspected bleeding disorder is one of the more challenging endeavors in hematology. And many features of the bleeding history, they are subjective. The family history may be unclear, and the extent of diagnostic testing is often highly individualized. So the things which are well established in bleeding disorders are history, physical examination, and some limited investigations. And even after practicing as a clinical hematologist for about 10-15 years, many a times it happens that I am not able to pinpoint the correct diagnosis why a patient is having bleeding. So this is important because things are evolving. This field is evolving. So many inherited bleeding disorders are there. We don't exactly know that what is the mutation, what genetic changes has led to this type of bleeding disorder. So it's evolving. So it's very important, and it's interesting to know. It's interesting to evaluate such patients. Next slide. So I would like to start with a 16 years old boy who presented with a spontaneous epistaxis for 2 days, and that was significant bleeding. So he required nasal packing. And in the family, his one of the sister and also mother had history of heavy menstrual bleeding. He was evaluated outside, which showed normal platelet count (PT), but there was prolonged APTT. So just think of possibilities. Your options are hemophilia, ITP, platelet function disorder, VWD. You can write in chat box what is the correct, what you think could be the cause of bleeding in this child. Most possible reason. Yes, very good. VWD is a possibility. So male child having bleeding, APTT is prolonged, but it's not hemophilia because hemophilia is a X-linked disease. So only male members are affected, but in this particular case, the female members like sisters, mothers, they are also having bleeding. Rarely, a hemophilic can also have bleeding in females if there is, suppose carriers are there. So the factor is level is low, they are not in the disease range, they can have bleeding, but that is a rare possibility. The common possibility would be von Willebrand disease. So with this case in background, I would discuss some theory of bleeding disorder, how to evaluate, and then we will discuss some one or two disease, and we will discuss for about half an hour, 30 to 40 minutes. If you feel that it's boring or it's taking too much time, you can stop me. We can discuss some of your problems. Next slide. Yes, so this is the thing that you see in your textbook. So whenever there is a trauma, so there is clotting pathway becomes activated. So there is endothelial injury. So the first thing happens is the primary hemostatic plug formation. When there is endothelial injury, the tissue factor is exposed. So platelet gets bind to that site, and that primary hemostatic plug is formed. Over the surface of platelets, all the clotting cascades starts. So the clotting cascade, it starts from extrinsic pathway, which leads to thrombin formation, and from there the intrinsic pathway is activated. So the clotting process is initiated by extrinsic pathway but maintained by intrinsic pathway. Okay, And these are the factors which are involved. So whenever these factors are deficient or dysfunctional, there can be bleeding. Next slide. Yes, this is about fibrinolysis. So what happens? What is the main aim? Main aim of clotting. So clotting process or clotting factors, they just help you in controlling the bleeding as well as preventing any unnecessary thrombus formation. So the fibrinolysis part is very important, where plasminogen activator inhibitor 1, alpha 2 antiplasmin, thrombin activatable fibrinolysis inhibitor TAFI, they all come into role, so that the thrombus, the clotting should take place only on the site of injury to control bleeding and not in the normal vessels where there can be thrombosis or some problem. So fibrinolysis is also very important. Next slide. Yes, and these are important. These tests you write day, night, you write every OPD, you write PTA, PTT, and these are the interpretation. If suppose only PT is prolonged, so what are the causes? So it could be inherited or it could be acquired. So inherited factor 7 deficiency is very rare. Acquired causes are common, like vitamin K deficiency, liver disease, drugs. There are many patients who had valvular heart disease, post valve replacement. They are on acetrom, they are on warfarin. Their PT can be prolonged. Acute DIC. If suppose PT is normal but only APT is prolonged, then what are the causes? Again, inherited and acquired. In inherited, it could be deficiency of factor 8 as hemophilia A, factor 9 deficiency, hemophilia B, or factor 11 deficiency as in hemophilia C. Or there can be deficiency of factor 12 and other factors which are not so important because they don't lead to bleeding. Or one case of von Willebrand disease, as we have seen in the first case. In acquired causes, it can be heparin or other anticoagulant, then acquired inhibitors of these factors, acquired von Willebrand syndrome, lupus anticoagulant. These are causes of isolated APTT prolongation. It's important. And if suppose both PT APT is prolonged, then acquired causes are again liver disease, DIC, severe vitamin K deficiency, anticoagulation, acquired inhibitor of factors. So anticoagulant, rodenticide poisoning, and inherited we can have either combined factor deficiency or common factor deficiency like prothrombin, fibrinogen, factor 5 or factor 10. Then we can have abnormality of fibrinolysis. So it could be primary hyperfibrinolysis where we will get some PT and APTT may be prolonged, fibrinogen will be decreased, D-dimer will be increased. So depending upon that, we can divide that it is due to primary hyperfibrinolysis or because of DIC or because of TTP. So these are just interpretation of some tests that we order. Next slide. Next slide, Anandji. Anandji, yes. So these terminology are very important. Like petechiae. So petechiae are pinhead skin bleeds. They are non-blanchable, non-palpable. They are the smallest skin bleeds. Petechiae. You can see these are some petechial spots over the ankle. Purpura. Purpura are larger than petechiae. So less than 2 mm size is petechia. Purpura 3 to 10 mm in size. Larger than petechiae is called purpura. Ecchymosis or bruises are more larger, more than 1 centimeter. Hematoma when there is subcutaneous blood collection. So hematoma is elevated, while ecchymosis bruises are non-palpable. They lie along the surface of the skin. Then primary and secondary hemostasis. So what type of bleeding one patient has? I will discuss this later. Then BAT scores. So there is a International Society of Thrombosis and Hemostasis is there, which has come up with a score of bleeding assessment tools. So bleeding assessment tools has some questionnaires for each type of bleeding. Like epistaxis, they ask 10 questions, and depending upon the answers, score is given. So suppose the score is high, more than 7, then this patient has significant, they needs evaluation, they need testing. But if suppose the score is low, then they don't need that means that bleeding is not significant. Investigation is not required, because the investigation, we should not write right and left, just PTA, PTT. We should be very methodical that, okay, this patient is having significant bleeding, who needs further evaluation. So the BAT score is a screening test which tells us that this patient needs further evaluation, and these patients can be just counseled, assured this is not significant bleeding. Hemostatic challenges. So this hemostatic challenge is important for bleeding history, bleeding evaluation, because suppose a patient has come with a uh, bleeding epistaxis, okay, first time epistaxis. So we will have to ask in the past that whether any similar bleeding was there or not, any hemostatic challenges that patient has encountered. Suppose tooth extraction was done and after that there was disproportionate excessive bleeding. That means this patient is having some bleeding problem. So suppose someone has undergone some surgery and the doctor has informed that no, bleeding was very heavy bleeding following surgery, which was not expected, and the patient required some transfusion. That means that particular patient has some bleeding problem. So hemostatic challenges history is very important. Next slide. And these are just just back. Anandji, yes. So these are petechiae and these are called wet purpura. This is very important. Purpura on the wet surface of mucosa. Wet purpura. So wet purpura is a very important finding which can indicate that this patient is going to have serious bleeding in future. So we will have to do something. We should not ignore. So all bleeding patient with a torch, we should examine the oral cavity to look for these type of black spots of our lips, our tongue, our buccal mucosa. Elderly male with periorbital, this type of ecchymosis, and these are important. If some other features are there, this could be a case of amyloidosis. Amyloidosis can have this type of periorbital purpura. Next slide. So these are the settings which patient can come. Patient can come with active bleeding, and there are some patients where patient is having active bleeding. We may need some intervention where there is no time for test. So there are some intervention that we can do to control bleeding, and we can do some routine investigation there, and further investigation we can do depending upon once patient is stable. And if patient is not actively bleeding, that means we have time, we can evaluate them properly, and depending upon what we get in history, physical examination and a screening test, we can move further. Next slide. Yes, so in the patient history, what are the things important? Underlying medical conditions are important, very important. Suppose someone has coronary artery disease, post PTCA has been done, patient is on echosprin, and patient has come with a large ecchymosis over skin. So this could be because of antiplatelet that patient is taking. So it's important. Underlying medical conditions, all medical condition history should be taken. Bleeding history, we should take duration, whether it is acute, first time problem, or it's a chronic problem, recurrent problem. Duration is important. Sites. So single site, if suppose someone is having single site, it is unlikely that there is some hematological cause for this bleeding. So mostly hematological causes or bleeding diathesis patients, they come with multiple sites bleeding. Or even suppose today it has come with epistaxis, in past may have bleeding from other sites. If suppose it is spontaneous, then it is most likely that this is significant. We need to evaluate. Hemostatic challenge, I have explained. Tendency to bruising is important. Interpretation of bleeding history. So whatever bleeding history we have taken, we have to interpret them. Family history is the most important for bleeding evaluation, because many a times there could be some inherited causes of either clotting factor deficiency or platelet dysfunction or thrombocytopenia, and family history helps in diagnosing such disease. Medication uses, antiplatelet, anticoagulation, anti-epileptic drugs, they are there. Even sometimes the garlic, they can cause platelet dysfunction. There are many herbal medicines, they can lead to platelet dysfunction and bleeding tendency. So each and every medicine that patient is on should be noted. Next slide. So targeted physical examination like cutaneous findings, petechiae, telangiectasia, bruises, hair follicle changes, because perifollicular hemorrhage, if it is there, it could indicate that person can have uh, scurvy, vitamin C deficiency, albinism. It can indicate that person can have some platelet function disorder. Other findings are also very important. So in a bleeding patient, if suppose you have examined skin, bleeding sites, then splenomegaly is very important. Many times a CLD portal hypertension with bleeding from suppose epistaxis or hematemesis, they can splenomegaly can indicate that it could be a case of CLD portal hypertension. Joint laxity, if it is there, it can indicate that patient can have some syndromic disease like Ehlers-Danlos syndrome, where there is some collagen disorder, where there can be some skin bleeding like symptoms. So it's important. Cardiac findings, because some cardiac disease, they can lead to bleeding dysfunction like platelet dysfunction. Macroglossia and other organ infiltration, as I have said, could indicate that it could be a case of amyloidosis. In amyloidosis also there is some factor, clotting factor dysfunction, which leads to bleeding tendency. And if syndromic findings are there, then we should note it and we should look for any syndrome patient is having or not. Next slide. Now coming to, once we have taken the history and have done physical examination, so now comes the role of test. What test we should order? So in the screening coagulogram, these are the tests that we should do. CBC is very important. So if you have habit of writing hemoglobin or platelet count, just stop it. Write CBC. That will tell you that whether patient is having anemia or not. If it is anemia, that means there is significant bleeding. Platelets, how they are, TLC, DLC, MCV, they can indicate that what could be the cause of thrombocytopenia or anemia. So CBC, one should write. Peripheral smear is important because many times they can tell you that whether the manual platelet count are okay or not. Even the platelet adhesion, if suppose like Bernard-Soulier syndrome is there, where platelet dysfunction is seen, and on peripheral smear you will see no platelet clumps, separate platelets are there. So morphology is important. For coagulation, screening tests are mainly platelet, PT, APTT, serum fibrinogen. These are the 4 tests that one should order in a suspected bleeding disorder first. Prothrombin time, activated partial thromboplastin time. Next slide. So, if suppose if patient presents with mucocutaneous bleeding, and the test which I suggested like platelet count, PTA, PTT, fibrinogen, they are normal. Still, they can have some disorder like platelet function disorder or von Willebrand disease. So we will have to do a specific test for that. Next slide. Yes. So these are the tests that we look for. Secondary hemostasis like PTA, PTT, thrombin time, reptilase time, specific. If suppose we get isolated APTT prolongation and we suspect that patient can have hemophilia, we have to do a specific clotting factor, say like factor 8, factor 9, like that. For primary hemostasis defect, if suppose PTA, PTT are normal, we have to do VWD, platelet function disorder. And there are many cases where all these tests can be normal clotting times, but patient is having bleeding dysfunction. So these are the tests or disease we should keep in mind. Next slide. So these are all about that we shared. Next slide. Yes. So if there is isolated lab abnormality without bleeding, suppose only APTT is prolonged, but there is no bleeding, then the approach is same as patient is having abnormal lab value with bleeding. And can be scenario where there is only family history of a bleeding disease. There also we evaluate, because if suppose a child has come whose parents is having bleeding tendency, but this child has not undergone any hemostatic challenges, but they are at risk of bleeding in future. So we have to evaluate for evaluate as I suggested. Next slide. What are the conditions where one needs referral to a hematologist? So these are some scenario where one has to refer for further workup, like active bleeding that requires administration of hemostatic products, abnormal initial testing that cannot be easily explained, test result consistent with a specific hematological disorder like VWD, ITP, concern about a bleeding disorder based on personal or family history, concern that a previous diagnosis may be inaccurate, concern about a bleeding disorder and upcoming surgery, question about whether anticoagulant or antiplatelet medication can be used in individual with a mild bleeding disorder, and family history of a bleeding disorder with upcoming surgery, delivery, or desire for prenatal counseling. Next slide. And yes, this is very important. So you have done, child has come with bleeding tendency, and you have done all investigations. There is no family history, all investigations are normal. So sometimes once in 6 months or 1 year, we get cases of Munchausen syndrome where a child inflicts trauma. It could be some psychological problem where he wants to skip classes or school or punishment, and he comes with this type of bleeding from some unusual surface where bleeding we don't see in a bleeding diathesis, bleeding disease. There also we have to take history. Child is usually very inflict trauma. You can see, you can observe their nails are very sharp, and in the absence of parents, they inflict some trauma. They come with bleeding, and their parents are also very anxious. So we have to again we have to take care of this Munchausen syndrome where they need psychological counseling and not the extra test or counseling or consultation. Next slide. So child, yes, they are. So these are all, just next slide, next slide. Yes. So now practical approach to a bleeding patient. So commonest cause of prolonged PT. In your practice, when you send PT INR, so the commonest cause of prolonged PT is not these mentioned or I have discussed. The commonest cause is when you send a sample for prothrombin time, there is delay in doing the test, 4 hours or 6 hours or something. Sometimes what happens, sample is taken in Patna and the sample will go to Mumbai, suppose some lab, private lab, and after 3 days you will get report of PT. So what happens, these clotting factors, they have short half-life, especially factor 7, and due to transit, due to transfer of samples, the clotting factors are low, they are reduced. So even in a normal person, the PT is prolonged. So the delay in lab error, we can say, is the commonest cause of prolonged PT in our practical experience. Others, if well done, correctly done prothrombin time, if it is prolonged, then other causes are there. Just like that, if you get prolonged APTT, again that is the cause, because factor 8 has half-life of 12 hours. If suppose you send that sample to centers, because all districts they don't have this one facility to do APTT or factor 8 or factor 9 level. So the lab error is the commonest cause of prolonged APTT. Many times we see when we repeat in local lab, they come normal. So these things we have to keep in mind. And next slide. So patient of bleeding from multiple sites, platelet normal, received FFP outside. So these are the cases which come to us where there is history of bleeding from multiple sites and just 1 or 2 days back received FFP. So how to evaluate? These are challenging patients because when you send clotting factors in that patient, so transfused FFP will change the value, will alter the value. So there we have to see the response, whether after FFP bleeding is stopped or not. If suppose after FFP in a suspected bleeding disorder, if after FFP bleeding has stopped, that means there is a possibility that there could be clotting factor deficiency, and we can do some test after giving gap of about 2 weeks. Like in a hemophilia patient, if someone has received FFP, we have to give gap of about around 2 weeks to get correct assessment of how much is the factor. Then patient with a spontaneous joint swelling received FFP outside. Again, that is the problem where we suspect hemophilia. We have to look for response, whether that FFP has helped anything or not. And after FFP patient has come, we can do some initial test and we can do the specific test for some clotting factor deficiency on later date. Next slide. So yes, so some cases, 40 years old male presented with petechiae over both lower limb for 4 days with history of fever, cough 7 days back. There was no significant past family or treatment history. On examination, he had nothing except petechiae. CBC was done which showed severe thrombocytopenia, 4000 with normal TLC, DLC, hemoglobin. So isolated severe thrombocytopenia. So provisionally we diagnosed him as ITP. So ITP is one of the bleeding diathesis which is very common. Next slide. Next slide. Next. Yes, just stop. So thrombocytopenia is one of the common cause of bleeding problem that we encounter. Whenever we see thrombocytopenia, we should look for peripheral smear and we should rule out pseudo-thrombocytopenia, whether platelet clumping is there or not. If it is ruled out, this is true thrombocytopenia. So in true thrombocytopenia, depending upon PS findings, we can have different differentials like cystocytes, TTP, HUS-DIC. If blasts are there, then it could be marrow disorder. We will have to do bone marrow. If microspherocytes are there, then Evans syndrome is a possibility. If lymphocytosis or atypical limbs are there, then infection is a possibility. If it is isolated thrombocytopenia, as in our case, it could be ITP, drug-induced ITP, viral infections, heat DIC, gestational thrombocytopenia, these are there. So for thrombocytopenia, good peripheral smear is important in evaluation. Next slide. So ITP is diagnosis of exclusion. We have to rule out other causes of thrombocytopenia, then we come to ITP diagnosis. So it's a common problem. It's a common problem. And bone marrow is not needed always to diagnose ITP. First line treatment is steroid. We should avoid NSAID. It's important. For painkiller, we can give tramadol, we can give paracetamol, but other NSAID like Dilona, Brufen, NICE should never be given. And platelet transfusion is not required in ITP except some specific indications. Next slide. Next slide. So ITP should not have splenomegaly. Remember, if you get thrombocytopenia and spleen is enlarged, it can never be ITP. Remember, do not forget to rule out HIV. HIV can present with thrombocytopenia only without fever, constitutional symptoms, weight loss in 10% of cases. For ITP, treatment is not required always. Treatment is only required if platelets are less than 30,000 or if there is bleeding. Papaya extract, goat milk, kiwi fruit is a myth. Please don't prescribe such medicines. In ITP, this is clear, well established that people are suffering more because of treatment than because of low platelet count. Next slide. So just for postgraduate students, for whenever there is thrombocytopenia and we have to transfuse platelets, so we have two options. One is single donor platelet, another is random donor platelet. So SDP is a large one. It is taken from a donor and it has around 250 ml volume. And this is RDP that you frequently get from blood banks. So this is from whole blood, 1 unit of whole blood, 1 RDP is prepared, and this SDP has 6 times more platelet. So preferably we should use SDP, but it is costly because FRS is the next slide. And this is the platelet agitator where platelets are stored in blood bank. They are not stored in freeze. They are stored at room temperature. So whenever platelet comes in your ward for platelet transfusion, try to transfuse as early as possible, because when you keep them at still on the nursing station, the platelet can become dysfunctional. So there are plates which always moves. They are agitator. It's agitator. So these plates are moving. They are not still. Next slide. Yes, and how much platelet to transfuse? Whenever there is thrombocytopenia and bleeding, and suppose you want to order for platelet transfusion, so a small bag of RDP per 10 kilograms. So for suppose 60 kilogram person, we give 6 units of RDP. or 1 unit of SDP. That is the dose for platelet. Next slide. Now coming to some example of coagulation disorder. So next slide. Next slide. So yes, so we all know hemophilia A. Hemophilia A is because of factor VIII deficiency. So suppose hemophilia A patient has come with severe headache. What we should do? So these are the options. We can do CT head. We can give Tranexa. We can take neuro opinion. We can write admission, or we can give factor VIII infusion. In a diagnosed hemophilia A who has come with, yes, so NCCT head, Dr. Yasmin has sent. But remember, in a diagnosed hemophilia A, if there is headache, consider it as IC bleed and give factor VIII infusion without delay. If you send for NCCT head, at least it will take 2 to 3 hours, and by that time that bleeding will increase and patient may die. So in a diagnosed hemophilia A, we should try to give factor VIII infusion first, and then we will do NCCT head and neuro opinion. If suppose there is no bleeding and we have given factor VIII infusion, it will not cause much harm. But if we delay, that will create problem. Next slide. The brief some few points about this one, hemophilia. Yes, next. Just wait. So these are just event trauma for children. Always we try to teach mother how to keep at home. These I have said. Next slide. Next slide. Yes, coming to hemophilia. So this is just about history of hemophilia. Next slide. Yes, so hemophilia A or B is a congenital bleeding disorder due to absence or deficiency of factor VIII or factor IX. So factor VIII deficiency leads to hemophilia A, and factor IX deficiency hemophilia B. Hemophilia A is more common than hemophilia B, and typically seen in males. Severity level is consistent between family members. Next slide. This is just say that carrier women when married to a healthy man, there can be hemophilic boy, and there can be carrier girl, and there can be healthy girl, one healthy girl and one healthy boy. So when a carrier girl marries to a healthy man, there is a risk that boy can have hemophilia. Next slide, because it's X-linked disease. If suppose a healthy woman marries to a hemophilic man, so there will not be affected hemophilic, but both the girls can have carrier, can be carrier. Next slide. Yes, this is the incidence. As I have said, hemophilia A is more common than hemophilia B. Next slide. Next slide. This is just 2-3 years back data. So just wait. So these are in India around 136,000 cases are there, and new cases per year are diagnosed around 1,700, and 21,000 cases are registered. So in India, around only 15-20% patients they are registered. 80% patients are roaming around in our society without any diagnosis. So it's very important. Whenever you get such cases of bleeding disorder, we should evaluate them. We should take history. Only then we will be able to correctly treat them. And many a times it happens that joint swelling, knee swelling, they are operated by orthopedic surgeon thinking that it's tumor, and the bleeding never stops, and many times patient loses their life. So it's important to catch each and every hemophilia cases. Next slide. Next slide. So yes, so
अरे बॉस
hemophilia
मुझे पता है वो कैसे नोट्स बने हैं बिल्कुल
hemophilia is confirmed by factor assay, and normally factor level is 40 to 150%. Next slide. Yes, so we can have three severity. So it could be severe hemophilia when the factor level is less than 1%, moderate hemophilia when factor level is 1 to 5%, and mild when 5 to 40%. Why this is important? Because severe can have a spontaneous bleeding, more bleeding, moderate can have less frequently bleeding, and mild can be normal until unless some hemostatic challenge has been given. So many times 70-year-old has gone for suppose some GI surgery and APTT was done, it is prolonged, and then we come to diagnosis of mild hemophilia. So we should remember that severity is important. Next slide. And these are some bleeding manifestations that hemophilic can have. Next slide. Yes, joint bleeding is characteristic of hemophilia. So they can complain that there is tingling or bubbling sensation in the joint, stiffness, warmth, pain, unusual limb position. This is important that a hemophilia patient, if he comes to your clinic and says that I am feeling some tingling sensation in the joint, that is the earliest sign of bleeding in the joint. There is no pain, no swelling, nothing, but only abnormal feeling in the joint. We should suspect that patient will have bleeding. If you say कुछ नहीं हो रहा है ऐसे vitamin खाओ calcium खाओ, they can come after 2 hours or next day with large joint swelling. So these are the symptoms which we should take seriously, and we should give factor replacement to stop bleeding. Next slide. So these are all about muscle bleeding. So muscles also can have bleeding. These are the iliopsoas, is the commonest muscle where there can be large hematoma, nerve entrapment, compression, neuropathy. Next slide. In hemophiliacs, life-threatening bleeding. So hemophiliacs, they can lose their life because if there is intracranial bleeding or neck and throat bleeding, abdominal GI bleeding, or if there is trauma, road traffic accident, or major surgery, where we have to give factor replacement about 100%. Next slide. These are some chronic manifestations. So in developed world, most of the hemophiliacs, they are living active life. They have normal joints. They are running. They are participating in activity. In developing country, in our country, what happens? Most of the patients, they are disabled. They have all complications of chronic bleeding in hemophiliacs. They are disabled. Next slide. These are all chronic manifestations. There can be pseudotumor because of large hematoma. Whole bone is resorbed. So these are difficult problems of hemophilia. Next slide. So education is the first step in the management of hemophilia. So education is important for family, parents, mother of the patient, and healthcare personnel community is important to help hemophilia. Next slide. So it's a team approach. Hemophilia management is a team approach. Next slide. This is just how things have evolved in hemophilia. So we started from whole blood to now factors are there, recombinant factors are there. Next slide. Yes, so these things are important, that what a mother of hemophilic should know. They should not do what IM injection should be avoided, cauterization should be avoided in at home. Furniture with sharp edges should not be there. Constricting bandages should be avoided. NSAID should not be given. Heavy sports like football, boxing should be avoided. They can do so soft stuff twice. They can play, use shoes. Factor concentrate should be at home. So whenever there is bleeding, mother should know, or someone should know that how to administer factor before coming to the doctor or pediatrician or hematologist. Prompt reporting trauma, headache, mild exercise they can do with factor replacement. Prenatal diagnosis is important. Next slide. Next, yes. So this is important. Price. So whenever there is trauma, whenever there is joint swelling, we should first prevent trauma. If there is joint swelling or muscles, whenever there is bleeding in hemophilia, we should give rest to that part. We should apply ice. We should compress that part. Crepe bandage can be used, and we should elevate that part so that the bleeding or the swelling is less or pain is controlled. And then the anti-hemophilic factor replacement is there that we should start as soon as possible. Once there is no bleeding, then physiotherapy can be started and psychological counseling should be included. Next slide. Next, so price is same that I have explained. Next slide. Yes, and anti-hemophilic factor, hemophilic factor, factor 8 or factor 9 replacement. So there are two type of replacement. One is on-demand therapy. Whenever there is bleeding, you give factor 8 for 2-3 days and stop. So most of the, in our state, most of the time we do on-demand therapy. Another type of therapy is prophylaxis therapy. That is, a child is there who is having risk of bleeding. So we will give 3 times a week factor so that he will be in the range of moderate hemophilia or mild hemophilia so that he will not have frequent bleeding. Next slide. So in developed world, most of the child they are on factor replacement prophylaxis. How to calculate? So for factor 8, we should weight into 100 divided by 2 is the 100% dose. And for factor 9, it's weight into 100, that is the 100% dose. And depending upon that, Where is the site of trauma? We calculate the dose. Next slide. This is as per World Federation of Hemophilia. So depending upon the site of bleeding, we have to give factor level, factor 8 dose and factor 9 dose. So standard protocols are there that we should follow. Next slide. And for minor bleeding, if suppose epistaxis, then head elevation should be done, ice should be applied, intranasal packing can be done, tooth bleeding, ice and pressure locally, hematuria, increased fluid intake, mild laceration and abrasion, we can give topical hemostasis, epinephrine solution, tranexamic acid. These can be used to control bleeding in minor bleeds. Next slide. Desmopressin can help in mild hemophiliacs, and their nasal spray can be used, or injection subcutaneous can be used. Next slide. Other treatment options are tranexamic acid that we commonly use whenever there is bleeding, but if there is hematuria, then one should avoid tranexamic acid because there is risk of clot and leading to renal dysfunction. Next slide. This is all about prophylaxis. I will not discuss. Next slide. Next slide. Next slide. So this is just if we give prophylaxis, then next slide. Then these are the advantages, and on demand, these are the advantages or problems. So comparison of prophylaxis and on demand. Next slide. No, back. So this is inhibitor is a problem in hemophilia management. So whenever patient is on factor replacement, they can develop antibody against factor 8 or factor 9. So that is called inhibitor. That is a major challenge. Whenever there is inhibitor, then we have to use bypassing agent in hemophilia. Next slide. World Hemophilia Day is celebrated on 17th April. So on 17th April, you can do some activity to create more awareness in your hospital. You can teach your colleagues about hemophilia. Next slide. Yes, so these are all about management. So regarding these things we have discussed. Next slide. Next slide. Next. So to conclude, yes, to conclude, first is history is very important. So a thorough history will guide that whether it is due to acquired bleeding disorder or it is inherited bleeding disorder. It is due to primary hemostatic problem or secondary hemostatic problem. And everything is important. Drug history, then other comorbidity is important to take note. Then history, a specific physical examination, mainly skin examination, then abdominal examination is important in physical examination. Then directed investigations, screening coagulogram that includes platelet count, PT, APTT, serum fibrinogen, and these 4 tests will guide that what could be the cause of bleeding tendency, and accordingly we will evaluate further. And that's all about. Next slide. So at the end, I would welcome you all for APCON 2026 that we are going to organize in Patna. Thank you all, and we hope that you will have some questions that we can discuss. Thank you. So Dr. Neha has question that can someone read question chat box? Okay, got it. CCT head. How to differentiate factor deficiency and condition having inhibitors to factor? Yes, very good question. So inhibitors, they can develop in disorders or factor deficiency like hemophilia. Okay, so suppose hemophilia A has developed inhibitors. So in that hemophilia patient, when we give factor 8 infusion, their bleeding will not be controlled. So that is the first indicator that maybe patient has developed inhibitor, where we have to do test for inhibitor assay. That is about factor 8 or factor 9 inhibitor, but patient can develop even acquired inhibitors. Elderly patients, they can develop acquired inhibitors to any factor or 1 Willebrand factor. So these are two different scenarios, but a diagnosed hemophilia having bleeding, and bleeding is not controlled by factor infusion, that is the first indicator of inhibitor development. Any more question? Yes. Is there any association between factor VIII deficiency and VWF deficiency? Yes, so factor VIII deficiency, it could be in your hemophilia A, or it could be a part of von Willebrand disease. So we have to look for, if suppose someone factor VIII is very low, like in severe hemophilia range, then possibly that patient is having severe hemophilia A. But if suppose factor VIII level is in moderate or mild range, then we may have to do VWD workup to look for that whether this is correct hemophilia A or von Willebrand disease. Then role of episodic replacement of clotting factor in prevention of bleeding. It's not clear. Clotting factor in prevention of bleeding. So clotting factor prevention prophylaxis, it depends. Suppose someone is planned for surgery. So depending upon what type of surgery, major or minor, we have to correct it. If suppose major surgery patient is planned, then we give 100% of correction, and gradually we reduce the dose of factor. If suppose minor surgery, then depending upon the surgery, we can give 20 to 30% of the required dose for 1 or 2 days. If there is no bleeding after that, then we can stop the factor replacement. Any more question? How to decide whether coagulation test will be done or platelet functions will be done? So see, the platelet function disorder or platelet related disorder, they are present with mucocutaneous bleeding, either skin bleeds or bleeding in the mucosa. Epistaxis, wet purpura, hematuria, GI bleed, they indicate that there is problem in primary hemostasis. There could be platelet is low or platelet dysfunction is there. While the clotting factor deficiency, usually they have deep bleeding like joint bleeding, muscle hematoma. So depending upon the pattern of bleeding, you can have idea that it could be platelet related or it is clotting factor related, and then you can do workup. In platelet function disorder, you will get normal PTA, PTT, and in clotting factor disorder, you may get abnormal PTA, PTT, or if suppose symptoms are suggestive of clotting factor deficiency, but PTA, PTT is normal, then we may have to do other tests like thrombin time, fibrinogen time, serum fibrinogen, and other rare clotting factor we may have to do. Next case, Dr. Neha. Role of anticoagulants in DIC. Yes, so most of the time this DIC, they have bleeding manifestations, and but it depends. Sometimes they have thrombotic tendency too. So the role of anticoagulation in DIC is there, where there is risk of thrombosis is there, but it is difficult to manage because they are severely thrombocytopenic. So giving anticoagulation where the risk of bleeding, platelets are low, is challenging. But there are some groups or some protocols are there where people have used short acting heparins with some success, but in real life it's difficult to practice. Any more question? I think there is no question, so So can we stop? आनंद जी,
यस सर।
तो और कोई क्वेश्चन है चैट बॉक्स में? ये सब तो हमने देख लिया। Anyone, any PG student who wants to ask any question, they can unmute and ask. If it's ये unmute करके पूछ सकते हैं आनंद जी?
जी जी, यस सर।
हाँ हाँ, तो कोई क्वेश्चन हो तो आप पूछ सकते हैं। Thank you everyone for joining and good interaction. It's a good topic and it's challenging sometimes to diagnose bleeding disorder. Novel treatment in hemophilia. So the field of hemophilia is evolving, and not only factors, but even there are some extended half-life factors are there. So the conventional factors which are there, we give twice daily. Extended half-life factors we can give weekly. Then there are many non-factor therapy, and many monoclonal antibodies are there which are approved in hemophilia, mainly in hemophilia with inhibitors, and also the gene therapy has also come up in hemophilia management. But the problem is of cost. All the novel therapy, they are very costly, so either the government or the WFH, they provide some resources for these therapies, but they are mostly for hemophilia with inhibitors. Gene therapy is being tried, and there are some centers in our country also has done research on gene therapy in hemophilia management. So maybe when more and more success in this field is noticed, they may be of use for general public. So these are there. Dietary restrictions in bleeding disorders. So dietary restrictions in bleeding disorder, there is no specific dietary restrictions are there, but as they have bleeding tendency, so anything very hard one should not eat, because there can be tongue bite or something like that. If very hot food can lead to some retropharyngeal hematoma or something like that, burn injury. And mainly, as I have said, that ice is one of the component for bleeding symptom control. So whenever there is oral bleed, we tell patient to take ice so that the local vasoconstriction can stop bleeding. So garlic can lead to platelet dysfunction. So if there is platelet disorder, we can tell them to avoid. But many standard guidelines, they don't suggest that we should say anything specific regarding diets, that one should avoid something, or one should take more to control bleeding. That is not so clear. So diet is not so, no specific diet can be recommended. That's it. These are all, there are some myths in mainly in thrombocytopenia, like using goat milk, kiwi fruit, papaya. This one, they don't have any evidence that they work in all sorts of thrombocytopenia. So thank you very much. I think there is no more questions. So thank you. आनंद जी,
जी सर। जी
तो क्या हम लोग एग्जिट हो जाएं?
ये यस सर, यस सर।
ठीक
यस।
ठीक ठीक ठीक। थैंक यू वेरी मच। थैंक यू आनंद जी।